In making this new scoring system, we first looked at clinical grades alone. On the left, you see 1,300 patients in our database that are classified by Minnesota risk, standard, and high. We then used machine learning to see whether we could divide this group of patients into 3 separate categories, and we could. And we've defined that now as a Manhattan risk that you see on the right. And we do now have a distinction between intermediate and low risk patients, which essentially divides the Minnesota standard risk patients in half. The Manhattan low risk consists of skin stage 1 with or without upper GI symptoms, upper GI symptoms alone, or skin stage 2 alone. And we published these data last year in Blood. We then asked whether we could use biomarkers to improve the classification of these patients. Now, the gastrointestinal GVHD biomarkers are reg3 alpha and ST2. These 2 biomarkers we combine into a single value called the MAP, Magic Algorithm Probability. And they serve as a kind of liquid biopsy of GVHD. In the picture here on the right, you can see a cross-section of a crypt in which an inflamed T cell has an activated inflamed T cell is now eating away at an intestinal stem cell and has already destroyed a Paneth cell. And you see the contents of these cells entering the circulation. And when we put together these 2 biomarkers, they form a single probability, and we've got these probabilities create the Ann Arbor scores. Ann Arbor 1 is low risk, Ann Arbor 2 is intermediate risk, and Ann Arbor 3 is high risk. And we have validated these biomarkers in now well over 1,000 patients. When we look at biomarkers and clinical symptoms and try to integrate them, we first started at the onset of GVHD when we are beginning our primary treatment. And we created what we call the Magic Composite scores. Here you see the Manhattan risk on the left, the Ann Arbor scores in the second column, the number of patients, the 6-month non-relapse mortality, and then finally the grade of the Magic Composite score on the right. And all of these scores really were grouped according to the 6-month NRM, which you can see in that 4th column there. So if the Manhattan risk was low and the Ann Arbor scores were low, Ann Arbor 1, that was a 3% NRM. If the Manhattan risk was low and it was an Ann Arbor 2, it was 12%. But if the Manhattan risk was intermediate and the Ann Arbor score was low at Ann Arbor 1, it was only 9%. These 3 combinations formed grade 1. The next 5 combinations formed grade 2, where we had all 3 low, intermediate, and high Manhattan risks, all 3 Ann Arbor risks, as you see in the second column, and all of these combinations made for non-relapse mortality in the 20 to 30% range, and we called that grade 2. Only when there was Manhattan risk high and Ann Arbor 3, the high risk, did we actually have a grade 3 where the NRM was greater than 50%. So what you can see here on the left are the cumulative incidences of non-relapse mortality in the first 6 months. The pie chart shows the proportion of the patients. About 60% of the patients had low risk Magic Composite score 1. About a third of the patients had intermediate risk Magic Composite score 2, and about 6 to 7% had high risk match a composite score 3. All of these non-relapse mortalities were statistically significantly different from one another. And in addition, the overall response rate at day 28, which is the gold standard for all clinical trials, was also significantly different. 80% for MCS1, about 60% for MCS2, and only about 30% for MCS3.